Hey, it's Becky here to talk about trends in Medicare drug spending from data I saw on Dartmouth Atlas that was interesting to me. First, a couple quick things about historical and projected drug spending in the US, not necessarily related to Medicare Part D, but as you can see in the last decade, it's been a fairly tumultuous ride as far as ups and downs in drug spending. Medicare Part D, which was enacted in 2003, was primarily enacted because they found that elders were foregoing medications because they were too expensive, and these medications could have helped prevent hospitalizations or surgery. Drugs make up about 20% of Medicare spending, and pretty much every party and every study I read continued to believe that that would be the case in the coming years. 1 in 4 people have difficulty affording medications, and Medicare Part D, with rising drug costs, is forced to look at why those costs of drugs are going up and what can be done to curtail the spending. Last year, 576 million prescriptions were written, and that was a big influx from previous years, and part of that is because more people are insured. We have a higher aging population, and there's also more providers with the ability to write prescriptions, like NPs and PAs. So there was a 10.3% per capita increase in drugs since 2014. And we're going to look at some of why that might be. So obviously, Medicare and Medicaid has become very interested in drug spending because in the last 10 years, up until 2015, there's been a huge increase in Medicare spending on drugs. So as you can see before, private insurance made up, the biggest out of pocket spending for drugs, and now Medicare and the U.S. government is responsible for the most payments. Drugs. So a big thing that Dartmouth Atlas focused on was the variation in spending and where the money goes and why it's so different from region to region. When you look at that map on the left-hand side, the darker green is more money spent on prescriptions. So the higher areas, they wrote more prescriptions, but the prescriptions they wrote were actually also more expensive. So the highest area of spending was up to 60% higher than the lowest area, which is a huge variation. So part of it has to do with the population demographic listed in those areas. It was interesting to see the racial disparity amongst Medicare Part D, recipients. So minorities were, up to 10 to 40%, on fewer medications than their white counterparts. After Medicare Part D, the disparity continued, and it's funny because white patients increased their prescription numbers by about 8% and their spending by 11%, whereas African Americans and other minorities, had a much smaller influx in prescriptions and, kind of leveled out with spending a little under 10%. So then when Dartmouth Atlas went back, they were unable to conclude whether that was because white patients overused medications or because minority patients underused them. There's also a difference in the percentage when you look at those areas and compare it to the map before. Some of the darker regions do correlate to this map, in which talks about what percent of the eligible population is enrolled in Medicare Part D. So, Florida, California, some of the northwestern states, which definitely correlated to the map we saw before in variation in spending. The next thing that they looked at was if the diseases and the comorbidities in those populations of those areas affected drug spending, and it did find through studies that about 30% of geographic variation was related to disease burden, but 30% is not as much as I thought it would be. So then they went to look at differing numbers. So in 2014, you noticed on that first slide there was a big spike in spending, and they are attributing that mostly to new specialty drugs. HIV, hepatitis C, MS, diabetes all came out that year. So then the next thing they did was to come up with other variations and reasons that there would be such a high variation amongst spending. So the first one they looked at was the higher number of prescriptions. The next one was discretionary medications. The third was brand name versus generic prescriptions filled. And finally, high risk medications. So this is a variation in total number filled, not in dollars. So you see the darker areas, you have beneficiaries in a 30-day period filling 62 prescriptions per beneficiary, which is a huge difference from 38 in other areas, especially the the western half of the country is much below the central and eastern side. So discretionary medications was their first go-to for differences in spending. So discretionary medications are those that have proven to have therapeutic use in some patients but produce no therapeutic result in others. So the degree at which they should be prescribed, obviously is felt differently around the country. So Medicare enrollees filled a prescription for proton pump inhibitors, which is listed as a discretionary medication, at a variance rate 15 to 45% in different areas of the country. Up to 31% of patients were on 2 or more discretionary medications. And this goes back to talking about how there's a variation in practice for the treatment of disorders. And discretionary medications were found often in categories like dementia, depression, sleep disorders, and things like that. So this is a huge disparity between areas and something that would probably have to be addressed at the physician level. The next thing was brand name versus generics. And like in the first slide, we talked about how brand names are much more expensive. So 26%, over a quarter of prescriptions filled, were brand named. In different areas, that varied from 16 to 36%. And clearly the areas with more brand name medications are costing more. So this is a chart about generics versus brand names and cost. And at the bottom, it actually breaks down the years by quarters. So, in 2008, there wasn't much of a difference, and see how large of a difference there is now in 2015 with the outpacing of brand names. So at the bottom of the slide, I also listed the 4 most expensive medications for Medicare that have paid out per date, and that just goes $2.68 billion for Lantus. Nexium, Advair, and Crestor, which are all chronic diseases. Obviously there are probably many medications out there that might have similar acting effects, and yet they're prescribing the brand name and costing so much more money. The final category to talk about was high-risk medications, and these medications are listed as dangerous for the elderly. They're associated with high rates of adverse effects, and most of the literature I read, stated fairly clearly that the risks do not outweigh the benefit. Despite this pretty solid opinion of them, 26% of Medicare enrollees filled prescriptions for these, since 2010. And the variation ranged from 14 to 43% nationwide, with some beneficiaries filling 2 or more prescriptions for high-risk medications. Some high-risk medications were used, skeletal muscle relaxants, resulted in a high fracture rate, probably because of falls. So not only are these medications costing money, they're a high risk and possibly causing other issues for these enrollees. So those were the couple areas that I looked at through Dartmouth Atlas, and I provided a lot of maps. So I hope to have a good discussion about it. Thanks.